Hi, I'm John Allen, a senior psychologist at the Menninger Clinic, and I'm happy today to have with me Janice Poplak, who is the Director of Social Work here at Menninger. And Janice and I are going to talk about how we engage families in treatment at the Menninger Clinic. So Janice, it's great to have you here, and
Thanks so much.
really appreciate your willingness to do this.
My pleasure.
So I've prepared a bunch of questions that I'd like to ask you. So is it okay with you if we just kind of roll through these questions and see what your thoughts are about them? Okay, so first, just broadly, how do you see the role of the family in patients' treatment here at the clinic?
Well, families actually have a very vital role. We know that our patients need a very strong support system during treatment and, of course, afterwards as well. And we think of the family as the key relationships, the current key relationships, and we want to focus on that with the family members and with the patients. And something that you've talked about quite a bit is creating secure relationships, secure attachments with these key people in our patients' lives, noting that the greater the security and the attachment, that corresponds quite positively to creating emotional stability. Mm-hmm. And of course, one of the goals of treatment is emotional stability.
Mm-hmm. Mm-hmm. Well, tell me more specifically, which family members are typically involved in treatment?
Sure. Well, this depends on the age and circumstances of the patient. Our adolescents, for example, are minors, so their parents are usually very much involved. They have to even sign off on certain aspects of treatment. We work with those family members twice a week, usually. Our young adults, the same. They're not usually self-supporting yet, and their parents are usually quite involved. Mm-hmm. Our adults in our adult units, if they're married, they work usually quite intensely with their spouse. If someone has grown children involved, they may be part of what we consider their treatment team, or long-term friends, individuals who will be there once the patient discharges from the program.
Mm-hmm. Now, who decides who's going to be involved? Does the patient have a say in who's involved or not involved in their treatment?
That's such a good point. Some of the work initially is maybe identifying who should participate. But the caveat is that ultimately the patient has to sign a release of information for anyone to be involved or even know they're here at the clinic. But to be involved in treatment, they do have to sign off on a release of information. And if that is an issue for patients, that's often a therapeutic issue that the social worker and the treatment team will work with the patient in order for us to understand why they may not want someone to participate, who generally would participate.
So tell me about the process of communication between the patient and the family and the team. How does that work?
Well, in our system, the social worker, who's a member of a larger treatment team that's interdisciplinary or interprofessional, the social worker is the liaison between the family and the treatment team. So through the process of getting to know the family members and doing a family history, the concerns and questions and issues that the family has gets communicated to the treatment team by the social worker in different venues, including team meetings and team rounds, in meetings such as that.
Mm-hmm. Mm-hmm. Well, now, could you just walk us through the process of involvement with the family from the point of admission all the way through to discharge?
Sure. We kind of look at treatment as an arc of treatment. And initially when the patient comes in, they're often accompanied by their family members. At that point, the social worker does try to meet with the family members here on campus and interview them for collateral information for history and for their experience with the patient. If that can't happen on the campus because family members may live elsewhere, not in our area. That's done by phone within the first 7 days. Once we have that information, we set up a weekly session with family members and usually the patient at a standing time once a week. That leads into a large team meeting at mid-stay in the patient's treatment called the Diagnostic feedback session, where the family has an opportunity to meet with the entire team and hear the diagnostic formulation, recommendations for treatment here and in aftercare. Later, as treatment proceeds towards discharge, we work with the family and the patient together on a discharge plan.
Now, it's my impression that a lot of family members have a sense of responsibility, maybe feeling guilty, or even at worst blameworthy for patients' problems. Is that the case? And if so, how do you work with those feelings?
I think it's often the case that family members feel they may be to blame for the patient's condition. And one thing we really try to strongly communicate to family members that there's no one reason that the patient has a mental illness or coexisting illnesses. These are complex illnesses and they're multi-determined. So we look at the biology, the psychological development, even the societal issues that may impact the patient and the family. And we also keep in mind that patients have different levels of vulnerability themselves. So stressors in life may impact them more than others in their family. And so these are the kinds of things we want to communicate to families, discuss, try to understand. So it's not about blaming anyone, it's about understanding. And we use sort of a notion that you've helped us develop here, the notion of mentalizing, that the family and the patient and even the staff be curious about what's gone on instead of coming with some assumptions or certainty about how each other feels and what has gone on in terms of their experience.
Well, tell me, what are the general, besides dealing with patient families' feelings, and maybe feelings of responsibility, what other kinds of problems, family issues do you deal with typically?
Well, often our families come when the patient arrives here, they're emotionally exhausted. They've been with the patient many months or even many years dealing with various crises that the patient has endured. They've endured it with them usually. And so we have noticed that family members can sort of rush in with solutions for patients. And this is an opportunity for family members to step back and think about patterns of communication, to be able to validate each other's feelings, because their feelings about things often sort of get buried in the doing, in trying to solve the problem. So we look at patterns of communication, hoping that families start to look at their own expressed emotion or develop expressed emotion that is appropriate and validating. And part of this process also may have sort of blurred boundaries for family members and roles in the family. So family members may be quick to do things for patients, and patients start to lose skills for doing things for themselves and taking up for themselves. So the other thing we try to emphasize is allowing the patient to take agency for their treatment, and hopefully agency after they leave here, so that they become more autonomous, more self-sufficient, and of course that builds self-esteem. This means that family members have to step back, which can be a scary process, and so we try to support them in that process.
Now, I would think, for families to step back, it makes a lot of sense, but I would think, when they're really afraid for their patients, their family members' welfare, for example, patients, engaged in self-harm or very destructive, dangerous behavior or suicidal, I would think then, the idea of stepping back would be especially challenging for families. How do you help them with that?
Well, one of the messages is that families have to understand that certain kinds of behaviors have to be shifted to professionals. And so we work on strategies on how that can happen. Different strategies, different scenarios that help family members recognize when they need to shift this responsibility to mental health professionals and not take it on themselves.
Right, so they're not alone with it.
Right. Yes, there's a certain sense of aloneness that is very devastating to families.
Well, let me ask you now about the end phase of treatment, the discharge process. So what happens if the team has one view, the patient has another, the family has another, if it's difficult to get agreement in the whole group about what the best discharge plan is? How do you work with that?
This is not uncommon. Often we have the patient wanting one thing, family wanting another, and the team wanting a different. So what we really do is, one way to think about this is that this is patient-centered care. We look at shared decision-making, a collaboration with the patient, the family, and the team to come to a consensus of what would be the best thing to do. Usually everyone has a valid reason and a valid point of why they want their plan to work. So we really come up usually with a plan A, a plan B, and a plan C. The treatment team may have the most conservative, or the family might have the most conservative plan, and the patient often may want the most liberal plan. But we will put together something that we feel at least, in the least, keeps the patient safe, keeps them in contact with providers, builds a strong community of support where they're living, and access to the kinds of professionals that they need ongoing to maintain the progress that they've made here, as well as to carry it forward.
Well, tell me, what do you see the role of the staff once the patient has left the clinic? Can the family expect that clinic staff members will be available for help after the patient leaves?
Well, first of all, we always encourage and love when we hear from patients or patients and their families to hear how they're doing, and of course we hope it's positive. But we are there as consultants for the patient and their family. If there is an issue in their aftercare program or their discharge plan, we certainly want to be there to consult with them. We can't do therapy or counseling because they're really no longer under our auspice legally. So that wouldn't be an advantage for them. But we will work with them to find the providers they may need and give other strategies and suggestions. But we always are happy to be in contact. A small percentage of patients may come back. They may come back a year or two later. They may come back in a few weeks. It just depends on the issues, of course. But sometimes if they find their discharge plan was not sufficient, they may come back to just work on that. Or having been gone, they sometimes come to the determination that there's certain issues they wish to work on more. And so they'll come back just to kind of focus in on those. And we're always happy to have them.
You know, it strikes me it's not unlike many other recurrent illnesses that sometimes people need to come back to the hospital.
That's right.
For treatment.
We hope that isn't necessary, but in some cases it certainly is, and they're always welcome.
Now, I have a question. This goes back a bit about communicating, again, the family with the treatment team. This would be after the patient has left, but also while they're here. What about email? What do you use email or rely on email, or is it phone contact? Or?
We try not to rely on email. Unfortunately, email is really not secure enough for the sensitive information that family members may want to communicate to us or us to them. So we do rely on phone communication. We can even do our family sessions on the phone. Email we may rely on just to set up appointments, but we try not to give any identifying information and certainly no sensitive information on email.
Yeah, so really to maintain confidentiality,
Yes.
email is limited to
It really is.
just practical, logistical
Yes.
matters.
Yes, well put. That's right.
Well, another question I have is, aside from Menninger, what other resources do you recommend to families for help?
Well, we do encourage families to really look at their communities to see what resources there are. We recommend that families get in touch with their local NAMI branch, which is the National Association for Mental Illness. This is a wonderful agency. They have a tremendous amount of resources, and they give a wonderful course for families called Families to Families, which allows families to learn about a whole array of issues in mental health, strategies, the politics of mental health. They do a lot of lobbying. But I think for our families, why it's so beneficial is that they meet other families with similar issues, and they really all end up bonding and helping each other. NAMI also has a lot of resources for the consumer of service themselves, such as housing, vocational programs, just a whole myriad of things that can be very helpful in their own community. And it's really national, it's a national agency, and it's really all over the country. A similar agency is called the National Alliance for Borderline Personality Disorder, and that's more for patients with personality disorders. And it also has a wonderful family education program called Family Connections. We can't really recommend that enough. It's so helpful. Our patients with addictions, we encourage families to join Al-Anon and CODA, because again, that helps them create healthy boundaries with patients, helps them understand what is really helpful to a patient, and what, because that can be counterintuitive, and how to get support from other people with similar issues. We ask people to check the Menninger website. We have quite a lot of resources on our website, including other podcasts that you have graciously been interviewed on an array of topics that are helpful to families. These are, as you know, 10-minute short podcasts. Dr. Oldham has more detailed podcasts with experts in the field of mental health, which can be very interesting for families. And we also list books and articles that Baylor faculty and Menninger faculty have written. So that's a great resource also for families.
Well, this is great. I think you've really given us a really good, broad overview of family work here. Is there anything that you would like to add, or anything else that we haven't covered that you'd like to mention?
Well, one thing that I hope families know about is our new family orientation that we give weekly every Tuesday. It's live on campus. If family members are here, they're welcome to join us. It's 90 minutes from 2 to 3:30 every Tuesday. Families can also access it remotely on the WebEx. And as long as we have their email address, we can send them an invitation.
Terrific. Well, I'm really glad that we had this talk, because my sense is that family work is just absolutely vital, as you said, to the work that we do here. And it's really wonderful. We're all blessed to have such fine social work here. And
well, thank you. And we appreciate the interdisciplinary support, because I think we know that it helps giving the best patient care. Yeah. Thank you, Dr.
Thanks
Allen.
a lot. Yeah.
You're welcome.